We are live.
Thank you, Sunilji. So, a very good evening, everyone. And my name is Dr. Piyush Bansal. I'm the chairman of the Scientific Committee of Maharashtra Ophthalmological Society. And me, along with Professor Archana Vare, who's the member of the Scientific Committee, we take extreme pleasure in inviting you to and welcoming you to attend the case presentation program today on retinopathy of prematurity. It's the first time that we have two young residents presenting cases on ROP. Our residents are going to be Dr. Apurva Sharma and her mentor, Dr. Anita Gaikwad, who is a medical retina and ROP consultant at HVD in Pune, and also by Dr. Sucheta Kulkarni, who's professor and clinical lead in the Department of Ophthalmology, Bharati Vidyapeeth Medical College in Pune. Our second presenter is going to be Dr. Gayatri Deshmankar, who's a junior resident in GMC CSN, that is Sambhaji Nagar, and ably mentored by Dr. Abhinya Surve, who's assistant professor at R.K. Damani Medical College in Sambhaji Nagar, and Professor Dr. Vaishali Unne, who's also professor at GMC in Sambhaji Nagar. So it is an extreme pleasure and honor actually to have our examiners with us, especially Dr. Professor Mangad Dogra sir, who's nobody in the world of retina is unfamiliar with that name, but to all residents, just to a friendly reminder. So he has been professor and head of department at PGI Advanced Eye Care Hospital in Chandigarh. It is one of the premium most institutes in the country, and the generations of ophthalmologists and retina surgeons and pediatric retina surgeons that he has trained is probably very few people can even come close to that. In fact, all of us retina surgeons, especially the ones who are interested in pediatric retina, we have directly or indirectly learned so much from him and still continue to do so. My teacher, Professor Subhadra Jalali, is a direct student of Dr. Mangad Dogra sir, and that is how most of the things that he has taught or percolated somehow into me and brought in an interest towards pediatric retina also. So welcome, sir. Sir is now senior consultant at Grewal Eye Institute in Chandigarh. I also welcome Dr. Purva Balvekar Date. She's my dear friend from Mumbai. She's also associate professor at Padma Shri Dr. D.V. Patil Medical College in Mumbai. I think it's very difficult for me to pronounce that name, a Polish teacher. If you can help me, Purva, your fellowship mentor.
Dr. Zivanovich.
Yes, so she was essentially
introduced oil.
Yeah,
Silicon oil.
So he was a lot of name and a lot of trauma as well. And she's a fellow of Professor Natarajan and subsequently a fellow of Dr. Zikovic. So welcome to you as well. We highly anticipate the questions that you're going to ask the residents, and hopefully a lot of residents sitting at home and watching will also be witness to all the learning. So with this, I hand it over to Professor Archana Vare to lead the program forward.
Yeah, thank you, Dr. Piyush. So good evening, everybody. So we have two cases today. So the first case will be presented by Dr. Apurva, and she will be presenting from till 8:30. And from 8:30, Dr. Gayatri, she will be presenting her case. So she'll have both the participants, they will have roughly 10 minutes for their case presentations. So now I request Dr. Apurva to share her screen and start presenting the case.
Yes, ma'am. Is my screen visible, ma'am?
Yeah. Can you make it full screen?
Yes, ma'am.
Okay.
Good evening, everyone. I'll be at the offset. I would like to thank my institute, HVD Eye Hospital, Pune, and Maharashtra Ophthalmological Society to give me this opportunity. I'll be presenting a case of stage 3 retinopathy of prematurity under the guidance of Dr. Anita ma'am and Dr. Sucheta Kulkarni ma'am. So to start with, the history is this is a case of 28 plus 2 weeks post-menstrual age male infant who was screened for ROP at the NICU of a district of a public hospital. Medical history includes extremely low birth weight infant admitted in the NICU of public hospital, who required intermittent oxygen therapy and was on RT feeding and was hemodynamically fragile. Birth history was the child was 25 weeks of gestational age with a birth weight of 660 grams, which categorized the child into extremely low birth weight criteria. Maternal history, the mother was 24-year-old primary with no systemic illness, no other comorbidities, and who delivered the baby at 25 plus 2 weeks via cesarean section delivery in view of preterm premature rupture of membrane. So examination was done at 3 weeks of chronological age. So PMA is basically gestational age versus plus chronological age. So gestational age was 25 plus 2 weeks and chronological age was 3 weeks. So, and the baby was, prior to the examination, the baby was dilated using tropicamide plus, which has a concentration of 2.5%, that is half the dose of phenylephrine of as compared to adult dose, and 0.8% of tropicamide. The general physical exam and the baby was dilated for 10 minutes interval for 30 minutes. General physical examination was normal, vitals were stable. In the anterior segment, there was no gross abnormality that was noted. Coming to the posterior segment examination, in both the eyes, the media showed vitreous haze of prematurity. The disc was normal in size, shape, and color. The macula was underdeveloped. There was foveal immaturity. The blood vessels in both the eyes showed peripheral looping with no plus disease. And in the periphery, we could see that there is a zone 2 posterior incomplete vascularization in both the eyes. So these are the fundus photograph of both the eyes. In the first picture, the right eye, we can see that the zone 1, which accounts for a circle which has a radius of radius from which is twice the distance between the center of the macula fovea and the optic disc. So this becomes the zone 1, and this is the zone 2 being the circle which extends nasally to up to the nasal aura, and the distance being similar inferiorly, temporally, and the superiorly. And in by ICROP 3 classification, there was a new terminology called zone 2 posterior, which was just 2 disc diameter away from the zone 1 circle. So in zone 2 posterior, we can see that there are some vessels that are reaching up to here. And in the other picture, we can see that there is some looping of the vessels that can be seen in the superior temporal quadrant. At this stage, the diagnosis was a 28 plus 2 weeks PMA male infant with zone 2 posterior incomplete retinal vascularization with peripheral looping with no pre-plus or plus disease. The management was the baby was observed at present, and he was followed up after every week. The patient was the findings were more or less similar to this presentation. Then the baby was followed at 33 plus 2 weeks. That means chronological age of 8 weeks. The positive findings showed that the blood vessels still showed peripheral loops, and in the periphery, as we can see in this picture, in the zone 2 posterior, there is the formation of stage 3. We can see there is double ridge and some popcorn lesions. That is nothing but the neovascularization posterior to the ridge, and this is around 1 clock. In the left eye, again we can see the double ridge formation, and stage 3 with the 2 to 3 clock hours of popcorn lesion that we can see here. So we called it mild pre-plus disease because we can see that there is some definitely there is some arterial attenuation and tortuosity and some amount of venous dilatation. And according to the ICROP reference pictures that are given below, we called it pre-plus in both the eyes. The next follow-up was done after 1 week. So at 34 plus 2 weeks, again, the positive findings were the blood vessel showed peripheral loops and tortuosity. And in the right eye, we can see that at zone 2 posterior, we can see that there is a double ridge sign in almost all the quadrant, and the popcorn lesions are there for more than 8 clock hours in the right eye. And we called it pre-plus. There is definitely some increase in the tortuosity and dilatation than the previous follow-up, but it is insufficient to be called as plus disease. In the left eye also, we can see that the double ridge sign is present in almost all the quadrants with popcorn lesion of more than 8 clock hours. So the finding was zone 2 posterior, stage 3 with more than 8 clock hours with pre-plus. At this stage, the diagnosis was 34 plus 2 weeks PMA male infant admitted in NICU with both eyes retinopathy of prematurity, zone 2, posterior, stage 3 with more than 8 clock hours with pre-plus disease. So the management was the baby was taken up for laser therapy. Before that, informed consent was obtained from the father, and NVM status was maintained for 45 minutes prior to the procedure, and special counseling on potential for further intervention like anti-VEGF or VR surgeries were provided to the parents, and the procedure was done under both under topical anesthesia, under pediatrician vigilance throughout. So the procedure that was done was both eyes indirect laser photocoagulation with green laser under topical anesthesia by a retina fellow. Intraoperatively, the patient was hemodynamically stable. There was no apnea episodes during the procedure, and the immediate findings that were noted were in the left eye. There was some VH noted, faint spots were noted, but in spite of that, the procedure was successfully completed in both the eyes. Post-operative management, medications were given. The child was started on tobramycin plus dexamethasone eye drops 3 times a day for 3 days, and parents were strictly advised to wipe off excess drops to avoid systemic absorption. And oral feed were resumed after 30 minutes, and the patient was then handed over to NICU staff in stable condition. And the baby was then followed up weekly for 4 weeks. So at 38 plus 2 weeks, the baby was again at a chronological age of 13 weeks. We can say that there was some decrease in the tortuosity of the vessels in both the eyes, and the periphery showed laser regressing ROP. So the 38 plus 2 weeks PMA had, we can see that the tortuosity of the vessels have decreased after the laser, and there are 360-degree laser marks and regression of the ROP. In the left eye also, there was 360. There was laser marks, and the tortuosity of the vessels decreased significantly. But there was some in inferior temporal quadrant. There was some resolving VH that was noted. So the child was followed up. Long-term follow-up was advised to the strictly advised to the parents. So at 48 plus 2 weeks, when the child was around 6 months of age, was again reviewed at our hospital, and we noted that there was complete regression of ROP, and there was no reactivation. When the child was at 69 plus 2 weeks, 11 months, around 11 months of age, again there was no reactivation, and the visual acuity was done using Taylor's acuity card, which came out to be 1.2 cycles per degree, which accounted for 20 by 800 20 by 800 according to Snellen's chart. Snellen's chart. So the patient was advised for continued follow-ups for refractive errors, cataract, and squint. So the take-home message for this is this case demonstrate that a successful management of more than 8 clock hours of stage 3 ROP through bedside laser, emphasizing the importance of screening in extremely low birth weights babies and low birth weight babies. Early intervention prevents progression to retinal detachment, and laser is the gold standard treatment for zone 2 ROP. Thank you.
Excellent presentation, Dr. Apurva. Can you please stop screen sharing? And I request Dogra sir to ask questions to Dr. Apurva.
I'm sorry. I'm sorry, sir. I'm unable to hear.
You can't hear me? Just let me see.
Yeah.
Audible, sir. Now you're audible, sir.
Now you're audible. Yes, sir.
Now, is it audible now? No.
Yes,
sir.
yes,
Yes,
yes.
you're audible.
All right. So there are a lot of things here, and this is something, the case, the way we did manage for a very long time, that is the way you have done here. And what is important here is this was an extremely low birth weight infant. In fact, extremely low birth weight infants, now they are, as you know, they are surviving more and more. So we have issues with them. and you have rightly screened such a infant at 3 weeks after birth. So that is something, I mean, I must say that is the way it should be done. And of course, when you dilate again, I think what precaution will you take when you dilate baby? So what will you take? What are the precautions you take?
The
Yes.
precautions again will be we have to wipe off the excess of the drops, because in preterm babies the cheek skin or the skin is so thin that even the cuticular supply, blood supply, will absorb the excess of the drops.
Any other reason? How is the baby? Baby is like in the, absolutely, it stays there. The drop would stay there even in the conjunctiva. It will get absorbed even through the NLD and others. You see, the baby, it's not like an adult. You are putting something which is up. The baby is up. So that's why it is much more. Rather from skin, it will absorb everywhere because, the baby is absolutely in the lap of a mother, or that is what starts happening. That's why it is so important. So otherwise you may have problems with that's right. And then you talked about once you examined avascular retina and loops. So where do you find especially the loops? What is the significance?
Uh, the loops are basically the shunts that are made. So I'm not sure, but these are actually the shunts that are between the arteries and the vessels. So, so they are. I'm not sure which quadrant they are made, but I'm sorry, sir.
Yes.
I do not know.
No, because it's very important for us to know about loops, because loops can signify so many things. And in our setup, the loops are not uncommon. So, in fact, if you go to our observation, which in fact was part of the ICROP classification about hybrid ROP, one of the biggest thing which we observed there was these large loops, and these large roofs can be, maybe they are related to our poor neonatal care or more oxygen being given. We don't know that part, but that is what start happening. So if you start seeing loops, you have to be much more careful, because this is not a simple avascular retina. So that's why I wanted to bring out this particular this thing. Otherwise, if you want to look at this, you can read this. This is in British Journal, maybe 2012 or sometimes, hybrid ROP described by us. So because these kind of loops, some, how, what is the significance? In fact, we go further as far as the management is concerned. What significance it has when you are managing?
This it is. It is signifying that there is a lot of VEGF production that is there in the uh, there, and the loops are forming uh, as a compensation to that retina. So it directs us towards it. This particular child might go to a plus disease.
You see, plus is a different ball game. We'll come to that. One of the most important thing is, which has been, Dr. Sucheta is here, that these loops are avascular. You see, you have to keep that in mind, and you need to laser inside the loops. You see, in your case, maybe later on it was a stage. Suppose you had these large loops and they were all over, and if you leave them, then you have an unfavorable outcome. So that is what is really significant, that you must remember that these loops are avascular inside, and they have been demonstrated several times on angiography and otherwise, and you need to also laser inside the loops. So that is what is important. Anything, Sujeta, you have to kind of add here, or you want to
Yeah,
ask?
and I request Dr. Purva ma'am also to ask questions.
Yeah,
Yeah,
yes. Please.
Purva
Please,
ma'am.
any one of you, ji. Yeah.
Good evening, everyone. So I'm a PG and UG teacher. So I'll be asking more of a questions which are related with the Viva, not about the management, but about the presentation. So regarding that, you have not drawn any retinal diagram. I mean, you have directly shown the photos, but what about the retinal pictures, color fundus pictures? So that is missing one. Then regarding the follow-ups, you have not mentioned the weight in any of the follow-up. The baby was 660 grams, but later on, how much the weight gain was there, it was not mentioned. So it was also important how the baby is progressing systemically also, and how the development is going on. I would like to ask you one question. So what about the other anterior segment findings you would like to see in any ROP screening?
So yes, ma'am. First of all, after dilatation, if the pupil is fully dilating, that means there is no neovascularization of the iris. If there are NVIs present, then the pupil will not dilate completely. Also, in preterm babies, there is tunica vasculosa lentis that is there on the ALC and the posterior capsule. So that was also that also needs to be noted. So if it is there, then the management and the laser might differ. The use of which laser we want to use.
Anterior chamber depth or something?
Yes, ma'am. In anterior chamber depth, as ROP classification, is stage 5C. If it is there, then there will be shallowing of the anterior chamber along with corneal edema and neovascularization.
And leukocoria also, if you want to mention.
Yes, ma'am.
And what about the counseling? How we are? Okay. Yes, sir.
No, that is a late thing.
Yes.
I mean, we are going to like stage 5, but there could be, you see, sometimes if you have a non-dilating pupil, what you mentioned, so how do you manage such a case?
Yes.
How do you proceed with that case? Because that is not also uncommon. We find sometimes it is all like vascularized there in front, and the pupil does not dilating. So what do you do there?
I'm not sure, sir, but I think we should go for anti-VEGF instead of.
Yes, suppose sometimes you are not able to, you see, procure anti-VEGF or it is difficult, you see. So what is usually observed in such cases? So what is the significance first? What kind of like significance it has once, because even somebody who's not really expert, if he's going to see that, he's going to suspect something behind. What is that?
Leukocoria, I'm not sure. Actually, I did not understand your question.
No, my question is, you see, you don't have these kind of vessels later on when you see leukocoria, that we are going for late stage 5, what you are talking. So we are not even talking about that. And we don't want them to go to stage 5 in any way. And since this is a common occurrence in our cases, so I think one of the most important thing is once you have seen this kind of thing, you have a very severe disease behind. It will be mostly you will find plus disease, again severe. You may have zone 1 disease. So you have to be ready with everything. So that's what is the significance. Significance is very important for you to know. And of course, these days you will prefer anti-VEGF, but once we had no anti-VEGF, we had no anti-VEGF for a long time. So I think, anything else? What we have seen, it is reported later on. I think Parijat did report it in one of the publications subsequently, that once you start you see depressing, it starts automatically dilating and starts stretching, and you can laser. You see, that's what is very important to know. You see, even if you don't have, of course, these days we prefer anti-VEGFs in these cases. So that's why I think we have to know about that. Why, if you see some findings, what would you find behind, and how you're going to be managing such a case? Yes.
Yeah, so Apurva, I just have one question. You mentioned about vitreous haze of prematurity. Any significance of that when you're treating?
Ma'am,
Can you just explain for the benefit of the audience or attendees? Can you explain that?
vitreous haze of prematurity is basically because of the transudates that are there the proteins that come out of the leaky vessels into the vitreous cavity. That is why there is a haze. So whenever there's a neovascularization, there is VEGF increase, upregulation of the VEGF. The hydrostatic pressure inside the vessels increase, and basically all the proteins, globins, they come out, and that I think causes the transudate material, that only causes the vitreous haze.
But when you showed the first image, there was no ROP in that child, right? Still, the child had vitreous haze of prematurity. So, any association with primary fetal vasculature? Or you're not aware? Okay.
I'm sorry, I'm not aware.
And
Yeah.
Purva
yeah.
ma'am, you want to ask something?
Just one question. What about the future counseling of the parents? I mean, you have written in your follow-up regarding that, but you have to emphasize till the age of 5 years or something, the child has to go for the proper follow-up. And one more small finding, when the VH was there, how frequently you followed up the child? I mean, I directly saw the follow-up was after 6 months after the laser therapy. I mean, you were following up the baby monthly or after a few weeks?
Yes, ma'am. The baby was followed up after every 3 to 4 weeks, and the last finding was at 6 months and then 11 months. But there was resolving VH. The VH eventually decreased and it resolved. But generally in babies, it generally takes a long time for the resolution of the VH.
And what are the complications you need to observe during this examination of these babies?
We have to see for any reactivation of the disease. So if there are any skip lesions in the laser, or there is any reactivation, any plus sign, pre plus, or further reactive ridge and the neovascularization at in any quadrant, we have to look for that. The parents also needs to be counseled for regular follow-ups, and for further refractive errors and amblyopia screening.
You see, you didn't mention that you did posterior laser, posterior edge was lasered. That you didn't mention. So one has to mention also when you laser, what kind of laser. Of course, you mentioned about 532. That is something we contributed to the whole. Again from our center, because I think it happened accidentally with me when 532 conked off. They used to say never do that, and I remember Anand Vinekar was with me, and I told Anand, we're going to use this, otherwise the child goes blind. And then we presented as a poster in American Academy. They took a writing from me, copyright, that we are doing something which is not. And that's how they didn't publish in ophthalmology. It got published in British Journal first. And it has changed the whole history. Now nobody looks for diode laser. It's the same laser using for anything. So I think what you have to do is that you have to mention about this posterior laser is not done in every case. That is why it is important. Usually, you would like to do it in a case like you had a stage 3 here. Otherwise, if suppose it was not stage 3 most of the time, in the beginning you may not do it, but it was clearly seen in the photographs which you have shown that posterior this thing has been lasered. And also, I think you didn't mention about doing any refraction, the retinoscopy under cycloplegic, because baby was almost a year. So you didn't mention anything about that. That is so important for us. Why it is important?
Because these patients are when the peripheral laser has been done, so these patients are more they can be myopic, so more than -5 -4 myopia can be seen in these patients. So again, that needs to be catered.
So I think it's very important. And subsequently, once the disease has regressed, you want to look for the visual development. How are you going to do that? So that part one should not miss. And that's how they require long-term follow-up. And they need to undergo everything, especially from that point of view, which you should not be missing. So that is something, I mean, you have to kind of mention and do it in such cases. Exactly. That is what I want. And anything else, Dr.
Jyota
Purva?
ma'am, Purva ma'am,
Yes.
Anita ma'am. Abhirya.
Apurva, I have one question. Which laser you used for the treatment?
We used 532 nanometers, that is a double frequency ND-YAG laser.
Correct. Used for the laser in HVD.
Yes.
Okay. So I think now it's time to move to our next case. But congratulations, Apurva, for a wonderful case presentation, and congratulations to both the mentors, Dr. Anita ma'am and Dr. Suchita ma'am. And I think with this discussion, we will move to our next case, and the next case will be presented by Dr. Gayatri. So Gayatri, please start sharing your screen and start presenting.
Yes, ma'am. Good evening, respected teachers. My name is Dr. Gayatri Deshmankar, and today I'll be presenting a case on retinopathy of prematurity under the guidance of Dr. Archana Vare ma'am, Dr. Vaishali Une ma'am, and my mentor is Dr. Abhinya Surve ma'am. The informants of this case are the parents.
I'm sorry to interrupt you, Gayatri, but there are some boxes that are those are seen on the screen. I mean, everybody can see, or only I am seeing the boxes?
No,
Yes,
even I
ma'am,
can
there
see
are
those
boxes.
black boxes.
Sunilji, Sunilji, are you there? Yeah.
Ma'am, is it okay now?
Yeah. It is better, but still we can see. Sunilji, are you there? Okay. But I can, yeah. Now it is
Right,
gone.
it is
But the
less
left side, there is a box down.
I think she can continue. The main text is visible.
Okay.
Yes, ma'am. A 25 days old female infant with a birth weight of 1160 gram was referred by the neonatology department to the ophthalmology OPD for ROP screening due to prematurity and low birth weight. There was no history of any blood transfusion, no history of sepsis, no history of any fever, rash, no history of meconium stained liquor, no history of any intraventricular hemorrhage detected, no history of any congenital abnormalities detected. The birth history, it was a preterm female infant born at 30 weeks of gestation. The birth weight was 1160 grams, which according to the WHO falls under the very low birth weight category. It was a single pregnancy delivered by cesarean section, and the baby did not cry immediately after birth and needed resuscitative procedures, and further was admitted under the neonatal ICU. In the antenatal history, the mother was a gravida 4, para 3, with 2 life and 1 death. In the previous obstetric history, there was a history of previous 3 cesarean sections with history of premature rupture of the membranes, which resulted in the preterm delivery. The mother was a known case of type 1 gestational diabetes mellitus and also a known case of hypothyroidism. Iron and folic acid supplementation with immunization was received. There was no history of fever, rash, or touch infections during pregnancy. There was no history of any exposure to any radiation or teratogenic drugs. In the neonatal ICU, the neonate had a stay of 25 days. The baby was diagnosed with respiratory distress syndrome, for which it was on ventilatory support for 5 days, followed by supplemental oxygen therapy for following 8 days. Considering the pedigree chart, there was no history of any consanguineous marriage. The first baby died on the day 1 of life. The second child at presentation was 10 years of age. The female child. This third male child was 5 years of age, and the fourth one is the affected child. There was no history of similar complaints in the family in either of the children. There was no history of any consanguineous marriage. Considering the general examination at presentation, the neonate was 33.4 weeks of gestation. The vitals were the heart rate of 114 beats per minute with respiratory rate of 62 per minute, and oxygen saturation on room air was 94%. On general examination, baby was pink and no gross abnormalities were noted. There was no significant history of cyanosis present. Considering the ocular examination, the baby was not following light, and the external features, that is the eyebrow, eyelid, and eyelash, were within normal limits. No abnormalities were detected. Under the anterior segment evaluation, conjunctiva showed no congestion, cornea was clear, anterior chamber was of normal depth. However, the iris showed a neovascularization and fine new vessels on the surface of the iris, predominantly at the pupillary margin, were seen in both the eyes. The pupil was well dilated. The lens status was clear. Now we'll see the fundus examination was performed using indirect ophthalmoscope, and these are the fundus images. First, considering the right eye, the peripheral vascular area, the arterial tortuosity and venous dilatation can be seen. Hemorrhage at the disc was also present, and vascular loops can be seen at the junction of the vascular and the avascular area. Multiple vascular loops could be seen. Considering the left eye, in the left eye, multiple intraretinal hemorrhages can be seen. The peripheral avascular area with arterial tortuosity and venous dilation almost in all the quadrants. And vascular loops again can be seen. Considering these findings, the zone involved was the zone 1 in both the eyes, with presence of plus disease, and aggressive ROP was also present. So considering this, this is the fundus diagram of my case. Following this, at presentation, at the first presentation, the one aggressive ROP with plus disease. At this point, the baby was advised intravitreal antivenom, but was lost to follow-up, and patient reported after 2 weeks. After 2 weeks, the anterior segment evaluation, there was significant neovascularization seen. At this age, the corrected gestational age was 36 weeks of gestation. This is the previous picture of the right eye. After 2 weeks, these were my fundus pictures. In this, the peripheral vascular area, arterial tortuosity and venous dilatation is seen. Also, a partial retinal detachment can be seen in the right eye, extending up to the macula with hemorrhages, considering as a tractional retinal detachment. In the left eye, after 2 weeks, there was peripheral vascular still persisted. Vascular loops can be seen, and a ridge can be seen of a stage 1 to stage 2 in few areas. So considering the description, in right eye, it was zone 1. Stage, because of the retinal detachment involving the macula, can be staged as stage 4B. It was extent was almost of 270 degrees with plus disease present, and as it was a very fast progression, aggressive ROP was also seen. In the left eye, there was zone 1 with stage 2 because of the ridge formation in few areas involving almost of 4 to 6 clock hours, and the plus disease was present. This was the fundus diagram after when the baby was presented after 2 weeks. So the provisional diagnosis was right eye zone 1 aggressive ROP with plus disease with progression to retinal detachment, which can be considered as stage 4B. And in the left eye, it was zone 1 aggressive ROP with stage 2 in few areas with plus disease, which can be called as hybrid ROP. The treatment advised for my patient was right eye lens sparing pars plana vitrectomy under general anesthesia, and in left eye it was intravitreal anti-VEGF were advised. So following the treatment, this was the presentation. After surgery 1 week, that we can see after the vitrectomy was done, we can see the traction bands were released, and after post surgery 1 month after laser was done, we can the laser marks can be seen. This is the right eye, and in the left eye, intravitreal ranibizumab was given. After one post injection 1 week, the stage has been decreased. The vascular tortuosity is seen to be decreased, and this is the fundus image of post injection after 1 month. Thank you.
Nice presentation, Dr. Gayatri. Will you please stop sharing your screen?
Yes, ma'am.
Yeah. And now I request Dr. Dogra sir to ask questions to Dr. Gayatri.
Yes, Gayatri, very well said, very well presented. I think it has
Sir,
Lots-
your voice is not clearly audible, sir.
Is it audible now?
Yes, sir. Yes.
Okay, I think there's some. Okay, so this has a very good case, very well presented as well as documented, and I think it has got a lot of things to sort of not only learn, but the way it has been managed, I must appreciate. And the surgery was done in your hospital.
Uh,
There was.
Dr.
sir,
Abhidnya, she is the surgeon, sir. Dr. Abhidnya.
Okay.
I did this surgery. It was done at our hospital.
This is your you do surgery for ROP.
So I have tried few
Not
cases
try.
since
You did an excellent job. You see,
Thank
my problem at this stage is not many people are doing ROP surgery, and they keep on calling me from all over, even in a place like Delhi, except for the All India Institute. Parijat Chandra, they don't do anywhere, and many of the cases are sent here, and they are totally kind of my team. Those who train by with me, they can't handle. So I think if you are doing surgery, you need to be congratulated. That is the biggest thing we require at this time. And the example is this case today, which you saved. And only thing is, why did you make it
Go
sort
to
of
stage 4.
stage 4B? Why you made it 4B? When
So,
even the diagram also perhaps doesn't suggest 4B. Okay.
so this baby had to be called almost 30 times for them to come at this stage at least. So it was very unfortunate. We have many such kind of babies whom we have to keep on calling multiple times to come and follow up for this case. And so I said 4B because during the surgery, it was almost extending up to the perifoveal area. So it has gone into the macular area. Hence the diagnosis I kept as 4B instead of 4A.
Okay. Because you see, the key here is, and that is something I highly appreciate, that you did surgery in time. Otherwise, this case was not only going to for B, it would have gone to 5, and everything would have been lost. And since during my time, when I was doing surgeries for many, many years, I only did for 4A and 4B. I stopped doing for 4, 5 because I never had that much time. So you see, the question is if we can do surgery at that time, which you did, and that's an excellent job you performed. So you can see the result there. That you see, otherwise it would have been that what we talked leukocoria straight away. So that is absolutely a fantastic job. Now, the question is to the presenter here that you saw here those vascular loops, and they were all over, isn't it? And they were all around. So once you classify, so how do you classify whether it was in zone 1 or posterior zone 2? Yes.
Sir, during the fundus examination, in this, we'll see with the 20D lens, if it is involving till the rim of the lens, then it is classified as zone 1.
You see, that is where the problem is. There are lot many things yet to be classified and known. It was never looked in the classification also. I did talk to Anand that they were not discussing because they don't see these loops. They are not, most of the people, those who are part of that system. You see, these loops are avascular. So you have to, you see, even if they are going beyond, they'll be still, you label it as zone 1. So that is why it is so important, apart from, of course, what we talked earlier. So I think you have to keep that thing in mind. And another thing is, which we talked earlier, you showed those vessels over the lens going all over. So what we talked earlier, that you're going to see a very severe disease behind. Even if, suppose, somebody has not peeped in and something like that is seen, how do you examine the anterior segment, by the way, when you are examining a baby? What is the best way to do that? Yes, Gayatri.
Uh,
How do we examine? We examine all the time, and we can see most of the time we pick up most findings.
are mostly it is not able to be
What worry
mm,
ma'am
No.
told you to add?
not able to answer.
You see, we do it all the time. How do we examine first? When we have
They're on
indirect
torchlight
also,
examination.
no, we don't do torchlight. We don't even put torchlight most of the time. So we do most of the things with indirect of Moscow. Once you use your lens and go nearby, just close, you will see all the details, isn't it? That is the way. We don't first go straight to fundus. We don't go to fundus. So what we are doing is we are going close. You see the magnified view. You'll see all the details, everything,
Yes,
whatever your case was, even if there are other issues that would be picked up right there. So that is very important initial part of examination. Then you go for the proper indirect ophthalmoscopy. So I think
yes, sir.
everybody should know that, and that's an important part of the initial examination. All right.
Yes.
So, and you talked about, you see, missing follow-ups and other things. I think that is a big issue in our country. And so, how do you counsel these babies? That is, the parents. How do you counsel? That is what the issue is. Basic bottom line is this.
Sir, we need to perform proper counseling of the patients that yeah, even though that when it is best to diagnose the disease at a very early stage, and if it is diagnosed as early as possible, proper follow-ups are required because if sometimes the disease can spontaneously regress as well. However, on the other hand, it can also reactivate or progress further. Close follow-ups are necessary. Further, also, if the disease directly ends up, if the patient is lost for follow-up and the disease directly ends up in a higher stage, then the reversal of the disease cannot be performed. And also, recently, various programs have been started which perform counseling of the patients for treatment, as well as after post treatment the patient should be counseled regarding the vision that the baby will have in the later life also, not even just near the treatment, but even after months and years of treatment, the um, follow-ups are required as disease can further reactivate and can present differently.
What you are saying is all right, but the most important part is you have to look at what is the situation over there, what you have seen, like in this case. So this required totally different counseling. You have to literally kind of not counsel this that you require follow up and this. No, no. I mean, this is written there in the eye. You see, you have to tell that if it is not done, so the baby is not going to see, and there is no replacement of eyes. So when I started way back in 91, so I would say, tell them, because it was a problem. They would come from anywhere in the country. Perhaps I must tell you history here. We were two people in the country. If up north, me in Chandigarh and Lingam Gopal in Shankarnidra, only two people, nobody else in the country. And either somebody landed there or came up to PGI. That's what used to happen. So we would tell them. You see, they would stay. That the sometimes I would tell, which was not really a right way, but that was the only way I thought, that देखो बच्चा तो सूरदास बन जाएगा और 100% बनेगा. That means कि there is going to be no vision. So sometimes they would even kind of make arrangement to stay, to do everything. What I'm saying is that you have to consult depending on what you are seeing there. Then at the same time, which you didn't mention, it's very important these days, we have a problem with injection. You have given injection here. So if somebody is receiving injection, yes, they have to be prepared for regular closed follow-up. Otherwise, you better go for laser. You see, otherwise it's a problem. Such babies otherwise will be lost. So I think we have to be very careful. You have shown a great case, but it has lot of, and especially if you, when you look at it, and I must say, Dr. Survi did a great job. If you are ever seeing a nasal area, any kind of elevation, any kind of a even flatter FVP, that is going to progress so fast, which happened in this case. So I think if you have that, then we are in big trouble. So that requires earliest management. If we don't do it, it's going to elevate like what happened in this case. I think a lot of education. Yes, Dr. Purva, you have some questions.
Thank you for wisdom of pearls, sir. It was very, I mean, the discussion was enriching. So, congratulations, Dr. Surve. Amazing surgery. And my questions to Dr. Gayatri. So, you have drawn pedigree charting. So, what implication or what is the importance of pedigree charting in this case?
Ma'am, so there are few conditions which we can which can be a result of consanguineous marriages, and also family history is important, as some of the differentials for retinopathy of prematurity are related to family history, as considered like familial exudative vitreoretinopathy, or which is autosomal dominant in nature, Nour's disease, incontinentia pigmenti. These can be considered as differentials of the disease, and they are linked because of their genetic, and family history is important because of that.
Okay, you have mentioned all the baby's age, but you have not mentioned parents' age also. So at least if it is a late pregnancy or something, that also it has to be pointed out. My next question is, you have written in the vision, baby is not following to the light. You are examining the patient at what age and when the following of the light will be noticed or observed? When the baby develops following of the light?
Ma'am, so at birth, ma'am, so basically this is a preterm baby. So the foveal, there is a fixation has not started. It begins around 4 to 5 weeks of just 4 to 5 weeks later, the fixation develops at almost 12 to 13 weeks after birth.
When
But
we
as
are
this is a
yes, so sorry to interrupt, but we have a limited time, so I want to discuss many things. So when you are presenting case in an examination, if it is not applicable, please just mention not applicable. Don't mention it if it is not following the light. Okay, you will be inviting more difficult question, unnecessary questions. Okay, so can you elaborate something on the NVI regarding the pupil and everything? Is it misnomer or it is actual NVIs, and what it does it signify?
So neovascularization of the iris, it can be seen as there is increased VEGF activity in retinopathy of prematurity. It can also be seen in the iris, and neovascularization can be seen. Also, there is a tunica vasculosa lentis, which is
the real NVIs. So are these the real NVIs?
No, ma'am. These are basically the remnants of the fetal vasculature that supplies the lens.
Okay, I'll go to the next point. You have shown very well presented diagrams, but only the central part was shown. The retina attached color coding was little bit missing. Only the blood vasculature and everything was shown. So you can complete the diagram with the background color, pars plana and everything. So it will be a complete diagram. Okay.
Yes.
And macula was shown attached in the first diagrams, and then it was not shown detached. But Dr. Surve has already clarified that during the operation she has observed that the macula was detached. That was the B. But in diagram you have not shown the macula was detached. So it would have been a stage A. Okay, you can rectify that.
Yes. Thank
you. And about the other eye, what is PAR? You have injected.
PAR,
so because the one eye is having very bad history. So what about the other eye? You will be taking care because it is an operated eye. So left eye also you have to be very cautious and careful. You have just injected.
Yes,
we have not done anything else. So it is a
PAR is persistent vascular retina. It can be said when there is mostly seen in the posterior and sometimes the temporal, and it can be diagnosed only when the diameter is more than 2 disc diameter. Then only it can be called as persistent vascular retina. Sometimes in cases of ROP, a small area of avascular zone can be seen in the anterior region, but it cannot be considered it as PAR unless because the diameter is less, and it can be.
What you will do if you see
Ma'am, ma'am, firstly we need close follow-ups, and I'm not sure of the treatment for PAR.
Okay, questions.
Sorry, ma'am.
PAR is a big problem. So there's a lot of work going on this area. So PAR after injection, that is where the issue is. So nobody knows at this time that this PAR is significant and we should do laser or we should give injection again. But what is known, and we know these days, like your case, suppose these vessels were not growing and they were still closer to zone 1, then you would perhaps, if suppose it is trying to recur, maybe give another injection. That is the only indication I find, so that vessels grow further. Why you want the vessels to grow further, Gayatri? What is the reason? Why?
Sir, the normal vascularization will be and the retina, the area of the vascular retina should reduce.
So you see, basically, finally, once you are lasering, you don't want to laser the retina like we did for old time. As Cheta is here, we used to come and we have some of these babies, of course, ROPs regressed. They have done well with high myopia. Sometimes just the posterior pole is left there. So you can imagine, you don't want that kind of retina to be knocked off. So you want to preserve as much as possible. So that is what you want, that vessels should go as far as possible, and then maybe you can do laser. Of course, you will always do laser once there is a reactivation or there is those things are of course very clear. But PAR is at this time something which we need a lot of work to be done. Yes, Dr. Sucheta, anything you want to?
Yeah, I just want to add that your case had a classic plus disease with dilatation and tortuosity, but in I think nasal quadrant of left eye, there was this white thread-like vessel. So sometimes you can see extensive thread-like white vessels, which can look like a retinal vasculitis kind of a picture. It is actually oxygen-induced retinopathy, and
Yes.
sometimes you can even see vessels very thinned out and very thread-like, thinned out vessel, which cannot be, are not comparable to the classic plus disease. But never underestimate the severity of such disease, or these are the most ominous kind of presentations.
It's very important. I think Dr. Sujita brought a very important point. Uh, Once we have a disease in zone 1, there is something also they have not classified that way, posterior zone 1. That means you have the vessels, only the half zone is vascularized or vessels are going to half zone. In these cases, sometimes you don't find those dilated vessels. These vessels, what Dr. Sujita is mentioning, is they may be thin. You see, so not that you look all the time for classic description of plus and keep on waiting. No, here it will be a big problem. So here, in case it is progressive, I think you have to intervene early and don't keep on looking at that it is going to go to that kind of a classic plus disease. By that time, you lose the whole thing. So that is why they need management very early. So in our cases, because we see this kind of oxygen induced, what she mentioned, I think we should be aware of that part also. That's very, very important. Where were you trained, Dr. Survi, for surgery?
Parijat sir, All India Institute.
Great, great, great. I think I have seen you there, perhaps. Maybe I met you there. Great, great job.
Sir,
So,
I would first of all thanks MOS and the whole organizing committee for
I'm talking
taking
to
a
you.
pediatric retina and ROP specially in the, because timely screening and appropriate management is the message we should go to all PG students.
yes, absolutely.
Yeah,
And
I'm
you deserve special mention that there is somebody in that part who can do a good surgery for ROP. That's great. And also, that means since you have your professors here, your other people here, they are supporting you, because the problem happens anesthesia. Problems happen your neonatology or pediatric department. They may not be really ready to, you see, get it on the same page. But if you have achieved this, it's a great news. Absolutely.
Yeah, thank you so much, sir. And with this, I would like to have feedback from all the mentors. So, Suchita ma'am and Anita ma'am, please give us the feedback about the session.
It was a very well organized, wonderful session, and I think it's many take home messages for postgraduate students. There is not enough of teaching on ROP at postgraduate level. It is mainly limited to fellowship training, but this is a great initiative by MOS to bring it down to PG level, which is the need of the hour. So I would like to congratulate entire MOS team and Dr. Piyush Bansal for this initiative. Thank you.
Thank you, ma'am. Thank you. Dr. Anita ma'am.
First of all, I will thank you to the Maharashtra Ophthalmological Society for giving the opportunity for the HV Desai resident to present the case. ROP is actually a new topic. First time they are presenting the ROP case. Baki, any other cases they are presenting, but the ROP first time this is the case they are presenting. So for them also there is a no background for the how to present the ROP case for the UG
Yes,
undergraduate students.
that's right.
So this is a very good platform for the future ROP presentations.
Thank you.
And once again, thank you. And it's well organized. Thank you, Archana ma'am.
Thank you. Thank you, ma'am. Vaishali ma'am and Abhidnya.
Good evening, all. It's been absolutely a delight, and I feel honored to hear from Dr. Mangat Dogra sir. Recently, we met at Jaipur, and always hearing him is such a delight. We get to know so much the more we read, and yet when these stalwarts speak, there is still so much new to learn. All the minor things, of course, sir's experience gives us very enriching knowledge. And it was nice to meet Dr. Sucheta, also my colleagues, and all the presenters, Dr. Gayatri and Apurva also did a great job, and the other mentors also. So thank you, Dr. Archana and Dr. Piyush, for taking this ROP. I've been struggling since past so many years to do the screening of the babies and all. So when the residents present it, it gives ample joy. So thank you for having me in. Thank you so much.
Thank you. Dr. Abhidnya.
I already said thank you for the whole session, and I think I also learned from the session listening to Dogra sir and Dati ma'am. I think it was a plus for me also.
Yeah, Dr.
For
Purva ma'am.
both presentations were good. First presentation on ROP for PG.
Questions by Dr. Karthik, yes.
Purva ma'am.
Yeah, it was a wonderful opportunity given to me, and the presentation, the mentors, everything was excellent. And it is a really good effort by the resident to present the ROP cases, which is very difficult. And they have studied very well. And it's kudos to their mentors also, because putting efforts to understand the ROP itself is a big task.
Yes, ma'am. Thank you. Dogra sir.
I must congratulate the entire MOS here, and of course the effort. Dr. Piyush mentioned to me that there will be a presentation on ROP. For me, ROP has been a mission and a passion. I told him that I had long time back said that if there is something to be done on ROP anywhere in India and I'm invited, I've always went. That is the way I took up this mission. So there was no way that I would have said that I'm not going to be there, even if wherever I was, I would have been part of this. But I'm so impressed. That means Maharashtra is doing a great job. If the residents are presenting so well, and they have documented the cases so well, that means a lot of things are being done, and that is really to be appreciated. It should be replicated also in other places, smaller places. Try to go to smaller places like SNCUs tomorrow once you are out of residency, and you see, you must carry on this mission. And absolutely, you have fantastic mentors here. The way everything has been presented and done, I'm sure the future for these ROP kids, which is the biggest, it is going to come like in few years time. You'll see, you youngsters, you'll see, this is like in South America, many countries, this is a number one cause of blindness. We are heading there. That is why we get worried, and we talk about it. And Suchita is here. We've been part of the task force by ministry and so many places. We know it, that what is happening at this time. So the question is, if you can pick up ROP, even if you are not able to pick, you have a confusion, and send in time to somebody who has a little bit, your job is done. That is what is very important, I think. So awareness is the first thing. If you are aware and you can do that much, I think our job would be done. And this should not only become a part of PG thing, has become, it has come in a big way in our time. When there was one paragraph, retrolental fibroplasia, differential diagnosis of retinoblastoma. That is what it was. And can you imagine today, it is such a big problem. We have a society, we have so much to be done for this. And so I think we have to also put this into the undergraduate curriculum, and where it should be, so at least they should be knowing that these are the babies at risk, and these are going to be more and more issues, because they are surviving in these SNCUs. They are coming with stage 5. So you have to design some way that you go there. So I must congratulate again both the presenter here, Dr. Purva and Dr. Gayatri, as well as all the mentors and
Thank
everybody,
you,
Dr.
sir.
Piyush
Thank you. Thank you. Thank you.
and Professor
In-
Vitali for the kind words she has spoken about me. Thank you.
Thank you, sir. At the end, I would like to request Dr. Piyush Bansal, the Dynamic Secretary of Maharashtra Ophthalmic Society, the Scientific Committee, Chairman, and for his concluding remarks and for the vote of thanks.
Thank you, Professor Bare. I think there's so much of information that I suddenly became the secretary from the chairman.
Sorry.
Right. So,
Chairman Scientific Committee.
just in continuation to what Douglas has said, so for the benefit of everybody over here, last year we had the first retinoblastoma cases presented by residents. It was a very proud moment in the retinoblastoma week. So apart from the faculty talks and the national faculty talk, as well as by Santosh Nava sir, as well as our state faculty talks, we also had 2 residents presenting. So that was the whole idea of projecting these lesser spoken about cases on a broader platform where people can go back and listen to questions. Their curiosity can be awakened, and they learn from a variety of teachers at a younger level. Now, for example, when I was a resident, that was 16 years ago. 16 years ago, when I passed out, I had not seen a single case of ROP. It was only in my fellowship that I saw my first case of ROP. Of course, I had read about it. I was extremely interested. Even if you just read Kansky, you're interested in ROP. It is something that is, it's a world of its own. I'm not even talking about pediatric retina. I'm just talking about ROP. So the residents today, they have ample avenues to learn, justly shown by Abhidnya Surve. I mean, a resident from a medical college presenting so well. See, HV Desai is a bigger hospital with a large number of screenings. But from GMC Sambhaji Nagar, a resident drawing such beautiful diagrams, documenting, and being able to answer questions so well. This is something to be really proud of. So I hope that we can do more cases of pediatric retina in the future with the quality of residents that we have in Maharashtra and Kerala and many other states. It's really astounding. So with that, I'd like to thank both our presenters first. So congratulations, Apurva, and congratulations, Gayatri. You guys are
Thank you, sir.
going to do really well in life. Of course, thank you to their mentors, Dr. Anita Gaikwad and Professor Sucheta Kulkarni. Dr. Abhinya, fantastic, like everybody said, and Professor Vaishali Une. Now, all words fail in front of our mentors. If I would like you to remember 3 things that Manga Dogra sir said. One is, of course, wiping of the tears, that you have to make sure that there is no absorption, excess absorption. Always lasing the inner loops. These it's so important. And the third most important thing that perhaps I feel that everybody should know is that you don't wait for it for the earlier time when it was 4 a.m. and you say it is an emergency. The moment you see it's stage 3, the moment you see there is pre-plus, the moment you don't even wait for plus. The moment you see all of that, you have to explain to the patient's parents repeatedly about how dire it is to treat immediately. Otherwise, the child will not see. And there is nothing that anybody can do about it. So extremely nice to have so many pearls from Dogra sir, and the pinpoint questions from Purva. Fantastic, Purva. These are very exam-oriented questions, and a lot of students in such a small span of time took back home a lot of messages for the exams. And a bigger thanks to Professor Archana Vare for stitching the entire program together to ensure that helps us do these programs, and to Sunil ji from Zadneotech, who does all of these webinars without any glitches. So thank you, everyone.
Thank you. Thank you very much.
Thank
Thanks
you.
again
sir.
for
Thank you.
inviting me. Thanks.
Thank you, sir. Thank you for being there, sir.
Thank you.
Okay, bye-bye.
Bye-bye. Good night, sir.